Today, we have the great pleasure of having as a speaker Professor Jeffrey Lazarus, Research Professor of IAS Global and Associate Professor of University of Barcelona, Spain, and a world-known expert in fatty liver, COVID, HCV, and handling of a large consensus movements on different major liver and health problems. Jeff, the mic is yours. I told you it's about 45 minutes presentation, followed by some discussion. Please, thank you very much again.
Great, thank you very much for the invitation, and I will just share my slides and then get started. So you should be able to see my slides now. As mentioned, I'm a professor at the Barcelona Institute for Global Health. I'm calling in now from New York City, where I'm also the city's new professor of global health, and I'm on my way to Prague later tonight to co-chair the EASL Steatotic Liver Disease Summit, the SLD Summit. We changed our name from the NAFLD Summit, and I'm going to explain a little bit about that process in the context of discussing, as requested, interdisciplinary management of MASLD, metabolic dysfunction associated steatotic liver disease, as NAFLD is now called, in the context of it being a pressing public health challenge. So I'd like to discuss a little bit around the nomenclature and why we changed from a more stigmatizing name to one with a positive diagnosis and with a focus on the metabolic comorbidities. Just very briefly around the epidemiology and the current situation of MASLD and NASH, formerly NASH, where steatotic liver disease fits as the liver's expression of metabolic syndrome, why it's challenging to diagnose, what may work best for patients, what kinds of models of care from diagnosis to treatment are there, and what should we be considering. So we know that language is powerful. It's important how we describe a condition to someone from a risk group or to a patient. We have had bad experiences with names related to COVID-19 earlier on, names related to HIV earlier on, and I would say the same related to MASLD, where there was much criticism about the definition of NAFLD and the prominent role that alcohol played in it. So I'll ask everyone if they can just go on mute while I'm speaking, unless you have a question or comment, in which case you're very free to interrupt and ask. Thank you. So, as we've worked over the last couple of years, and possibly some of you were involved in that process, certainly leading experts from Italy and around the world were, as I'll show in a moment, we asked really, what are issues the current nomenclature related to the current nomenclature, and how, and can they actually be addressed? What's the importance of steatohepatitis and disease definition and endpoints? How should the role of alcohol be accounted for or not? And how might name change impact disease awareness, clinical trials, and regulatory approval pathways? Finally, can an alternative name reduce heterogeneity and allow for future advances? So we took this on board over 2 years ago in a process chaired by Dr. Maru Ranella, representing AASLD, Dr. Phil Newsome, representing EASL, and ultimately over 250 nominees from EASL, ALE, as well as Apostle, ASLD, and AMAGE, and over 56 countries were represented in the global NAFLD process. There were various working groups, as you can see on the bottom left, related to hepatology for both adults and pediatric hepatology, alcohol-related liver disease experts, endocrinology, pathology, clinical practice, industry, and patient organizations. And since I'll be focusing on models of care, this already gives you an indication of the different groups that we're going to need and specialties that we're going to need to be involved when we're actually addressing MASLD and not just addressing the name change. So the nomenclature, and I'm sure you're all familiar with this, published simultaneously in the EASL, ALE, and AASLD journals, landed on MASLD and MASH, but also created a category called MET ALD, which is MASLD, and increased alcohol intake. I won't get into those details, but it allowed us to really better categorize the patients who had a metabolic condition along with their steatotic liver disease, but also were drinking more alcohol than was recommended, but not enough to be categorized solely as alcohol-related liver disease. So we have MASLD, MET ALD, and ALD, and I'll primarily be focusing on the far left on MASLD. So what does this mean for the field? I already mentioned a number of fields that were involved in the nomenclature process. And of course, we need to reach even more fields, primarily primary care, so the general practitioners understand that MASLD is an important issue that they also need to be addressing. It's an affirmative definition, recognizing, as mentioned, the overlap with ALD. It's non-stigmatizing, and it's applicable for existing data. In fact, a number of studies are showing that the NAFLD MASLD overlap can be as high as 98, 99%, which is excellent in terms of continuing previous studies and cohorts, also with regards to regulatory issues, and we were able to more accurately categorize patients and reduce the stigma related to it. So the process now, and this webinar is part of it, is the dissemination to medical societies around the world, getting their endorsements. We have, I think, over 70 endorsements. That number's increasing all the time, and not just hepatology, but also endocrinology, nutrition, obesity management, and other societies should be aware of this and endorsing it. Government and regulators, as well as globally, including industry, both diagnostic and pharmaceutical companies. And there was recently a FDA workshop, the EMA's equivalent here in the US, to discuss what this actually means. Now, the diagnostic criteria for MASLD is that you'll have one or more of the following in the presence of confirmed or suspected steatosis. So that's diabetes or prediabetes, central obesity, hypertension, or metabolic dyslipidemia. I won't go into all of the clinical details, but those are the conditions which one would have in the presence of confirmed or suspected steatosis, resulting in a diagnosis of MASLD, not merely non-alcoholic fatty liver disease, but the presence of a metabolic condition. And globally, and this is NAFLD data, but I think we can say it's about the same for MASLD, the rates are going up. So if we used to talk about 1 in 4 adults, now we talk about more than 1 in 3 adults with MASLD, and it's important to run these studies given the diversity and the differences among countries, in sub-national entities, in different risk groups. So we also carried out, for example, a study focusing on people living with HIV and found really the same numbers, around 38%, with a wide confidence interval of people with HIV also having MASLD. We know that obesity and metabolic syndrome are the drivers of the MASLD increase. And here you see an obesity prevalence map, and even if the data isn't entirely reliable in every country, you see rates of over 30% among adults in many countries, and that's driving the MASLD increase. MASLD is part of the group of obesity-related disorders. So everything from cardiovascular disease and CKD and various cancers to osteoporosis, sarcopenia, hypothyroidism, and so on. So again, this is an issue that needs to be addressed far beyond just the hepatology clinics and other liver specialists, but to be addressed by a whole range of specialists as well as primary care at the initial stages. The presence of MASLD, if I mentioned it was, around 30% in people living with HIV, it's well over 50% in those living with type 2 diabetes. So you can see that number on the right from one study, the Yanasi et al. Study from 2019. But if you see in the footnotes there, a recent systematic review and meta-analysis found 65% MASLD prevalence in patients with 2 TDM. So the numbers are quite high for MASH, over 37%, high for advanced fibrosis, over 17%, and additional studies are more or less confirming these high numbers, and you see a difference by region, but really it's high everywhere and just very high in some settings. One of the challenges with NAFLD and calling a disease fatty liver disease was that not everyone will be overweight or obese with MASLD and MASH. We also have a lean NASH phenotype, and we see prevalence of MASLD in those without obesity, those who are lean, depending where you are, as high as 25 or 30% in parts of Asia, and often lower, around 10% in Americans and Caucasians, and it was estimated at 16% in Italy in one study. So that's important. It's important when we're talking about MASLD to remember that not everyone will be obese, and therefore physicians, primary care physicians and others need to be aware of that outside of the liver space where we're well aware of it. There's a huge economic impact of MASLD and MASH. This study focused on NAFLD, and you'll see the estimates here in both Europe and in the US in the tens and hundreds of millions of euros or dollars, depending on where the study was carried out. There are direct costs to the healthcare system, and there are indirect costs to economic productivity. This continues to be calculated. We need more investment frameworks on the cost of inaction, because this is an important advocacy tool to policymakers and decision makers so that they understand that there are real economic costs associated with this condition specifically. And finally, MASLD is a cardiovascular risk. This has been increasingly studied, and I won't go through all of these studies, just suffice it to say that there are both specific clinic studies as well as reviews now showing this close link. And as you see in the image on the left, that depicts quite well the linkage between obesity, cardiovascular disease, and MASLD, or in that study, NAFLD. Liver-related mortality, I think we're all aware, is linked to fibrosis stage. But what's interesting is that not everyone who's diagnosed with MASLD is aware of their fibrosis stage. So one study reported the importance of telling patients what their fibrosis stage is, and that this actually resulted in them adhering more than the cohort, or the group that was not informed of their fibrosis stage, to cell interventions. People who knew they had and so on were adhere better to lifestyle when they actually knew their fibrosis stage. So that is important to patients. All of this has implications for the management and care pathways. For everyone diagnosed with MASLD, we need a minimal set of metabolic assessments: hyperglycemia, dyslipidemia, hypertension, obesity, further workup for cardiovascular disease and other conditions as appropriate. For those with obesity or diabetes, they all need to be tested for MASLD and liver fibrosis. And if cirrhosis, they'll also benefit from screening for liver cancer. And there are treatments that benefit both MASLD and concurrent metabolic conditions. So even if we don't have a MASH specific drug right now. Hopefully that will change. We do have lifestyle interventions that can be prescribed, metabolic drugs, and in extreme cases, bariatric surgery. Some of those lifestyle recommendations for treating MASH include a reduction in caloric intake, weight loss and sustained weight loss. It can improve steatosis, but needs to be even greater if it's going to improve MASH and fibrosis. Exercise alone, it may reduce steatosis, but the effect on other histologic features is unknown. And no heavy alcohol consumption. And if diagnosed with MASLD or MASH, really the recommendation is no alcohol intake at all. If you look at the bottom here, you'll see, lifestyle changes can lead to, sort of a 5 to 10% weight loss, which can have an impact. But the drugs listed on the left lead to greater weight loss, as does endoscopy and as does surgery. So while we recommend lifestyle interventions, we know that there are other interventions that can be more effective, but they bring with them greater challenges, including costs and access to that kind of care. So the overall paradigm probably looks something like this. In terms of obesity, it's dietary modification and physical activity, obesity medications. In terms of cardiovascular disease risk, management of metabolic syndrome. In terms of malignancy, addressing liver cancer. And in terms of liver-directed, we have no FDA or EMA approved drugs. Several are in late-stage clinical trials or entering the regulatory process. Now, in order to diagnose MASLD, we have various options. So there's a workup after seeing abnormal liver blood tests, and this isn't always done, particularly in primary care. So interventions like the iLift, the Intelligent Liver Function Test, created by John Dillon's group in Scotland, is an interesting approach to that. There's incidental findings of steatotic liver on imaging and targeted assessment in patients with metabolic risk factors. I think there's increasingly a number of recommendations that everyone with diabetes or overweight should be tested for MASLD, and they can be tested in a range of ways, including with non-invasive tests through steatosis scores like the fatty liver index, through imaging, ultrasound, MRI, transient elastography, and histology by liver biopsy, what is considered the gold standard, but which we're increasingly moving away from through a series of either concurrent or one after the other of non-invasive tests. The FibroScan is increasingly portable. We use one in Barcelona that we take into the field with us. They've been outfitted into mobile units, and as TE increasingly becomes mobile and accessible, I hope that we'll see an increased number of people using them outside of hospital and clinics, and really testing first for fibrosis and then for the cause of fibrosis. Is it viral like hepatitis B or C? Is it metabolic like MASLD? Is there another reason? So we need to start changing the paradigm from work I've been doing, for example, in hepatitis B and C, to instead be focusing on fibrosis and what the causes of that are. Another promising development is the use of AI, of artificial intelligence in liver diagnosis. And there's a whole range of ways that AI can be used. It's increasingly being tested and used for diagnosing, used for identifying those at risk. There are obviously people better placed than I to discuss all of the applications of AI, but it's important to remember that it is increasingly being used, and I think it will be more so in the future as it becomes increasingly accurate. There's a whole range of apps that are being used with biohacks and different ways of coaching those who are diagnosed or at risk of MASLD to improve their lifestyles. So what are some of those patient care needs? Well, they really need a multidisciplinary approach. As I've shown, we're not going to be able to address this just from the liver clinic. We need to be looking at a whole range of specializations and primary care, and we need increased coordination and collaboration between disciplines, which is just not always very easy for a variety of reasons, including inaccurate or insufficient clinical practice guidelines, reimbursement issues, space issues, and so on. So when looking at models of care, what we really want to ask is, what are the services being provided to a patient in a particular setting? Where are they being provided? In different buildings, on different floors, virtually? Who's providing them? And how are they coordinated and integrated within the healthcare system? A few years ago, we carried out a systematic review of the studies, and we only found 7 published studies of comprehensive models of care related to fatty liver disease that answered those 4 questions. So in terms of the what, the where, the who, and the how, these are the recommendations we made. First and foremost was to increase the use of non-invasive tests. I'm going to come back to that. On the right, you'll see, for example, establishing where co-location of services for the treatment of MASLD and common comorbidities is feasible. Defining the structures of these multidisciplinary teams. Not everyone needs to be there all the time, but we need to figure out which specialists, which other care providers need to be with the patient, where and when, and how do we coordinate this across the healthcare system. So this can be a tool that can be used to look at your own clinics, your own hospitals and practices to see, are you providing the most comprehensive care to your patients and those at risk of MASLD and MASH. Now, in terms of the priority issue around NITs, we found in a small study of 35 survey respondents that 14 different NITs were used, of which FIB4 and TE were the most common, but the cutoffs used for the same NITs for MASLD risk stratification varied between clinicians. And we know that lower and upper cutoffs have important implications for test performance and clinical decision making. So it's incredibly important that that we follow the guidelines, that the guidelines are aligned, because if we're going to move away from the liver biopsy, also one day in clinical trials, regulators and others need to know that we're all using the cutoffs at the same levels, or at least according to the guidelines, because we know the levels might be different in some countries, like in India. And an optimal care model, taking account of the where, the what, the who, and the how, would involve primary care providers and endocrinology testing, nutrition and lifestyle interventions, health psychology. I know that one of our nurses constantly refers to the mental health issues that MASLD patients report. Obviously, liver specialists, cardiology, and others as comorbidities are identified. So ultimately, we need to be moving away from this disease-centered care, the sole focus on the liver, to people-centered care, looking at comorbidities and health-related quality of life as well. That means models of care need to converge. We drew this image, and on the left, cardiology is open at one time, hepatology at one time, the pharmacy is somewhere else. Maybe it's in the hospital, maybe it's not. We have an example of where it's across a highway where patients have to go over a bridge. So we need to think about how we can integrate care, either co-located or with much easier referral systems, so that it's less fragmented, because when it's more fragmented, there's clear evidence that patients will get lost to follow-up. They simply won't come to their appointments. So all of this led the EASL International Liver Foundation which I was vice chair of, and Dr. Massimo Colombo from Italy, all of you I'm sure know him, was the chair. The foundation has since been folded into EASL, but at the time of the EASL International Liver Foundation, we said this is truly a neglected public health threat. It has a significant impact. It's a silent condition, both from policymakers, but even among the public health community, where those addressing other NCDs really don't address MASLD. It's a global issue. Over 30% of adults around the world affected, and a complex challenge. It requires us to work across disciplines and sectors to find solutions. So one of the solutions is to build consensus in the field. And from 2 years ago, we have this global public health consensus around MASLD, emphasizing the importance of leadership in the field, better characterizing the human and economic burden, raising awareness. And here we said reconsidering the terminology. So we have done that. Treatment and care, from lifestyles to drugs for comorbidities, and hopefully soon approved drugs for MASH. Taking a whole of society approach, something that was really discussed a lot during the COVID pandemic, going beyond the liver space and addressing MASLD in the context of other NCDs, because it doesn't occur really in isolation, involving patients and community perspectives, not just from liver groups, also diabetes, cancer, obesity, and defining and implementing models of care. The focus of this talk and an issue I've already mentioned, but I'll emphasize the importance of local care pathways, making multidisciplinary care models the norm, equipping providers with the necessary tools, and expanding the use of implementation research. Following the global consensus, the EASL Lancet Commission, focusing on protecting the next generation against liver disease complications, reported as well that the estimated prevalence of MASLD or SLD is high and on the rise, and recommended specifically addressing the impact of marketing of alcohol and ultra-processed high-sugar food and drinks to children, to advocate for improved health promotion through access to healthy diets and physical activity, and that the endocrinologist should not miss MASLD for the reasons I already stated. So this is a liver-focused study addressing issues like ultra-processed food, lifestyles, and diabetes. That's how the field is starting to change, and that will require multi-stakeholder education programs, including to reduce all forms of stigma. This figure 15 from the EASL Lancet Commission reminds us that stigma is complex. There's public stigma, structural stigma, even stigma in healthcare settings. And all of this contributes to self-stigma. The problem with self-stigma is that it leads to care avoidance and delayed care, an increase in the number of people with severe liver disease, an increase in unhealthy behaviors. There can be a spillover of stereotypes to unrelated patient groups, and it leads to increases in health and social inequalities. The inequalities, the inequities linked to the social determinants of health have been shown that low socioeconomic status is associated with higher NAFLD prevalence, higher NASH prevalence, and lower socioeconomic status leads to higher liver cancer rates. So we need to think about who's coming to our hospitals and clinics, what are the challenges they have in accessing care, knowing that those of lower socioeconomic status have worse health outcomes. Now, in the policy realm, an area I'm specialized in, when we looked at, do countries have a MASLD or MASH, formerly NAFLD or NASH strategy, we found that none do. Now the US and India, do have strategies, but we said, well, what about mentions of MASLD and MASH? We searched for NAFLD and NASH at the time in other strategies of key comorbidities and related issues like diabetes, healthy habits and nutrition, and obesity. And when we searched, we didn't find it. When we searched even for the word liver, we rarely found it except in the context of delivering on obesity care, on diabetes care, and so on. And if you look at the orange row at the bottom, you'll see that even where there should obviously be some mention, even in passing or as a footnote, of MASLD in an obesity strategy, national or subnational, or a diabetes strategy, it was not the case. And I think that's important in Italy and in other countries around the world to make sure that clinical guidelines in adjacent specializations are mentioning MASLD. We've taken the issue of MASLD to the global level, linked to the Sustainable Development Goals. A score was developed and countries were scored from 0 to 100. In the results there, you can see that 18 of the 195 countries scored greater than 185. The lowest was in Niger, the highest in Japan. And while this score to a large extent followed the actual Sustainable Development Goals score, as you can see in the image on the right, it puts the liver at the center of the Sustainable Development Goals, goals that were adopted by all United Nations member states. And what we did was agree on the targets and goals that were most related to MASLD, like in yellow there, hunger and food, malnutrition, like in green, non-communicable diseases and universal health coverage. But also on the left there, 11.7, green public spaces. If we don't have safe urban green spaces, it's not possible for many people to exercise, and then they cannot increase their physical activity like some clinicians will prescribe them to do to address MASLD, particularly when it's reversible in the lower fibrosis stages. Recently, over 350 experts from almost 100 countries and territories developed the first research and action agenda for the field, focusing on turning the tide on steatotic liver disease. You see in the image on the right, these 6 domains are the same as those domains used in the Global Public Health Consensus Statement, ranging from leadership and policies to treatment and care. A Delphi methodology over just 2 rounds was employed. Research and action priorities were reviewed and ranked. The agreement levels increased from one round to the other as the statements and recommendations were revised. And the final agenda includes 28 research priorities to tackle steatotic liver disease and 29 action priorities to turn the tide on steatotic liver disease. They were published this month on the cover of the Journal of Hepatology, Easel's Journal, and also in press, but available online in AASLD's Journal of Hepatology. In Journal of Hepatology, it's the Global Research Agenda, and in Hepatology, it's the Action Agenda. Thank you to everyone who participated. Also, if you're on the line, this was a huge undertaking to really create the first global agenda in our field. As I start to conclude, if we're going to be talking about models of care, we need to think about how do we increase the community of practice more generally. So as was mentioned in the introduction, I have a background working in HIV, and in the field of HIV, you'll find medical anthropologists, sociologists, psychologists, many, many different specializations addressing HIV and AIDS. And you really don't find it to that extent in steatotic liver disease. So this is just one attempt here to identify where we need to focus. That includes associated non-governmental and community-based organizations, a range of industry, and that includes medtech and digital health, as well as pharmaceutical companies, diagnostic companies. The community, as mentioned, this includes caregivers, along with patient advocacy groups from a range of organizations, not just liver. The broader research community, including public health and global health, and obviously a range of healthcare providers, because we're talking about metabolic dysfunction associated steatotic liver disease and not just non-alcoholic fatty liver disease. In May, we held the first World Health Assembly side event The World Health Assembly is the highest decision-making body for the World Health Organization, setting their strategies and action plans. And at the EASL headquarters, a range of groups. And if you see these logos, you'll say, well, there's a lot of liver organizations, but on the bottom right, you can also see the World Heart Federation, the bottom left, the European Association for the Study of Diabetes, groups working with pediatric care and obesity were also present, like the European Association for the Study of Obesity. And we tried to explain to WHO, who was there with their director of the Unit on Non-Communicable Diseases and others, our vision of ending steatotic liver disease as a global public health threat. Even if this has not been described as such by WHO, it is, given the present prevalence and the outcomes, both clinical and related to health-related quality of life, and our mission in the field to mobilize action for steatotic liver disease. The Minister of Health of Brazil was there, as well as depicted here, the Minister of Health of Egypt. Egypt, a country that's been remarkable in their approach to eliminating hepatitis C, describing that story of how they addressed hepatitis C, the minister saying that he believes the main achievements on biohepatitis happened because of three things: planning, preparedness, and political will. That's political will that's driven from a bottom-up approach, but also top-down, in this case, from the minister himself. We launched our call to action with the minister and others signing it, calling on all stakeholders to address a range of issues, including better collaboration, addressing needs for responses at the local, national, and global levels, involving affected communities, and promoting the new nomenclature of steatotic liver disease in all settings, from doctors and surgeries and hospitals and public health buildings to adoption of the new language at all relevant medical and political forum. Finally, I think it's important to position MASLD within the NCD agenda. Where strategically should MASLD sit in the non-communicable disease agenda? So I think we need to look at how we can have a collaborative response for the shared vision of addressing NCDs, building partnerships and collaborations beyond the liver health community, as I've been stressing, both at the clinical level through models of care, but also at the advocacy level, and identify where the MASLD/MASH community can lead efforts and where it can support and amplify the work of others. World Obesity Day, World Liver Day, World Diabetes Day should all be addressing MASLD and MASH as well. So we should prioritize engaging with diabetes, obesity, and heart disease communities, advocacy groups, NGOs, community groups, patient advocacy groups, but also our clinical colleagues and other key stakeholders as needed and as listed here, improving communication more generally and particularly with other professional organizations. So where do we go from here? We have a strong body of work from which to build. And I think now is really the time to accelerate our efforts. We have a new nomenclature for steatotic liver disease. We recognize the role of alcohol by recognizing and creating the category of MET ALD. And we've just held in May a World Health Assembly side event. Excuse me. We have a growing burden around the world that requires policy change, from primary and secondary prevention to treatment and care. And we need to grow our community to engage policymakers, policy influencers, and patients as stewards of change, and think globally and bring a common voice for more awareness and action on fatty liver disease. So even if we're sitting in our clinic or our hospital or our patient organization, we also need to be thinking globally, but taking that action locally, so we can grow the community of practice for steatotic liver disease and bring a united voice to global conversations like the Healthy Livers, Healthy Lives collaboration that has been leading the effort to develop a global research and action agenda and engage more heavily with the World Health Organization. I'd like to conclude by acknowledging hundreds of panelists in all of the different studies that were presented, large global collaborations starting to bring cohesion to our field, the development of the policy index, setting a baseline for the policies that need to be in place in countries, as well as important collaborators like the Wilton Park think tank in the United Kingdom and the Economist Intelligence Unit that has been helping us to reach key opinion leaders in Asia, Latin America, and the Middle East. So I will conclude there and hand back to the chair. Thank you.